Pruritus, a rare complication associated with histamine release in the skin, not thought to be dose related. And if you're having problems with pruritus, my experience is don't try and use an antihistamine. It doesn't work very well. So just change them to something different that doesn't cause the same problem. You don't see it very often though. Respiratory depression, once again, in the palliative care patients, if you use the drugs carefully, you don't run into those sorts of problems. I guess my classic story of running into problems with opioids was when I was at the Mater. We had a young man who was in his 30s who came in because he had cancer. We didn't know where it was, but he had one of those Dalmatian bone scans, just lit up like a Christmas tree. And he had a lot of abdominal pain. He was vomiting. And we put him on morphine, and then, trying to get on top of his pain, he was on a syringe driver and the dose just sort of went up exponentially. And this young guy, he got bladder outlet obstruction, he got drowsiness, he went on to be narcotized, he aspirated, he got pneumonia. So he sort of got everything wrong, and he had to be given Narcan to reverse him. It was a great learning experience. That's what it was. And then eventually, we titrated his opioids and started again and used other things to try and help with his bone pain. And what he ended up having, he actually went on, he had continuous vomiting. This was another feature of his disease. So anyone hazard a guess what he actually had? What sort of tumour he had? No, it wasn't a carcinoid. No, he didn't have a brain tumour. In fact, we scanned him from head to toe, CT, and we couldn't find... Sorry? No. Prostate? No. He had a pancreatic carcinoma. And the reason that he was vomiting is he had a gastric outlet obstruction. So, and it was diagnosed post-mortem. And, I don't normally get a lot of post-mortems done, but this guy had everybody stumped. No one knew what was going on. And he actually got home for a period and then came back in and was still vomiting. It was, one of those learning experiences again. Urinary symptoms, yeah, so sometimes patients can get urinary obstruction, so you just need to be aware of it. Myoclonus, it is interesting for me over even the time that I've been at Redcliffe, that we don't see as much toxicity as we did, and maybe it's because of the way we use opioids a little bit differently now. But for some patients, they do get quite bad myoclonus, so that they can't hold a cup because they'll tip the hot tea over them and that sort of thing. But it's not as common as I remember it being. And there's certainly literature on this, so one needs to be careful if you've got renal failure, obviously. M3G has been implicated. Certainly if a patient is on other psychoactive drugs or sedatives, then it's said that myoclonus can be worse at times. But in actual fact, the treatment of myoclonus is to actually give them further sedation. So you sort of decrease the amount of myoclonus that they get, but that's sort of going into sort of semi-conscious states. Once again, if it's a problem with toxicity, change the opioid. And maybe it's because we're using more hydromorphone now than we did before that we don't see it as frequently. I don't know. Case history. A 78-year-old fellow with diabetes, metastatic rectal cancer with liver mets, lived in an aged care facility in Caboolture actually, and we were asked to admit this fellow by the GP because he had bloody diarrhoea and not controlled on Lomotil and loperamide. The GP had started kale and opium, and we didn't have a bed to admit this patient, and so must have been when I was going up to Caboolture. No, it's actually a Friday afternoon. It was a Friday afternoon. So I actually drove up to Caboolture to see this fellow and spoke to the nursing home staff, and they were happy to look after this guy, but they felt he needed a palliative review. And he was wasted and anorexic, but still drinking fluids. He was quite confused, and he had some myoclonus. He was dry clinically, and he complained of pain in the perineum and lower abdomen. He had, on examination of his belly, he had a palpable sigmoid, and on rectal examination, he was impacted. He had overflow diarrhea, and which is the trap that we all fall into from time to time. But it's the thing that we should think of. It's rare to get a palliative patient who has diarrhea unless you're looking after HIV patients or something like that. But in the cancer setting for patients who are on opioids, it's unusual. So the alarm bells need to start ringing. And the problem was that this poor guy actually had a perianal cavity and malignant perineal infiltration. And so he had a lot of pain, and so passing a stool was really uncomfortable and painful. And I particularly remember, it's, PRs that I remember, or, you could write a little book, PRs that I remember. Does everyone remember doing their first rectal exam? I do, because I was terrified at the time, because I did it in an exam, my surgical term. And so the surgeon said, I want you to do a PR on this patient. I said, I've never done one before, sir. He said, well, it's time to start. Anyway, this was summer. The room was small. It stunk of feces, and I nearly threw up. Nearly disgraced myself. It was not very pleasant. So he'd had some bloods done. HB was low. Creatinine was creeping up. Urea was creeping up a bit more, so that just added weight to the fact that he was dry. Calcium was normal, and he'd had his glucoses checked, and they were good. So what would you do? What do you do with this patient? So I suppose you could shuffle him off to Caboolture Hospital. The nurses didn't want him to go to hospital. So they were his current drugs: aspirin, furosemide, mirtazapine, Kapanol. My assessment of this fellow was that he was really crook. May have been approaching end of life, so last 24, 48 hours. Symptoms: he was confused, he was constipated, he had rectal bleeding, he had this perineal sort of abscess, he wasn't eating, he had renal failure, possibly hypoglycemic, although his sugars weren't, 1s and 2s, they were 3s. But still, that's a worry. And he's dry. So all I did for this guy was stopped everything that I didn't think was absolutely necessary for his comfort. Consider subcutaneous fluids. Changed his background opioid because he was toxic on the morphine. We actually gave him some suppositories to try and help get his bowel moving. We used some local anaesthetic to try and help with his perianal pain, and then just regular review. So that was the plan. Just change tack for a minute. You talk a little bit about neuropathic pain. So neuropathic pain is often a difficult pain. So if you're looking at difficult pains, you think of bone pain, which is often very difficult to manage, and neuropathic pain. So they're the ones that you sort of have difficulty with. So with neuropathic pain, you can look at non-invasive therapies. So you might consider TENS. The thing about TENS is that often it's very short acting. People get benefit for a little while and then the benefit seems to wear off. You can look at drug therapies, and they're usually oral. You might have a very superficial pain. So something like, post-herpetic neuralgia. You might consider using, capsaicin cream or something like that to try and treat that pain. And then you can look at invasive therapy, so neural blockade, cordotomy, or in the non-cancer pain. I've never seen a palliative care patient who's had a spinal cord stimulator put in. They're very expensive. I don't even understand how they work properly, but they don't tend to use them in cancer patients. They're for chronic non-malignant pain. Gabapentin, and I think next week there's some more slides on gabapentin, but gabapentin is sort of, it's what the pain people talk about. Gabapentin or the new gabapentin, pregabalin. So gabapentin was originally licensed as an anticonvulsant, and it was an add-on drug. And if you talk to Chris Staples, who's the neurologist who comes to Redcliffe, he reckons it's a rubbish drug in terms of its anticonvulsant activity. And I said, why do you think that? He said, it doesn't have enough side effects. But we know that it does, and there's been a number of trials done looking at gabapentin, and there's some. I don't think it's on this week, but I think next week there's some more information about the use of gabapentin in analgesia, and it is an effective agent, but I don't think it's the panacea that a lot of people make it out to be. So, and the other thing about is the absorption. It's an active absorption process. So that active absorption process actually gets saturated. If you want the levels to go up, you have to give quite high doses. So that can be a problem. That's not such a problem with the other drug, pregabalin. So time to Cmax, so 3.2 hours, half-life 6 to 8 hours. So normally the drug's given 3 times a day. It's excreted in the kidneys, so once again, renal function is important to know. The site of action is really this alpha 2 subunit, so it affects calcium channels. And I mean, that's how a number of the older anticonvulsants work as calcium channel blockers.